I'm Jeff Marcus. I'm the director of the Duke Cleft and Craniofacial Center.
I'm Pedro Santiago. I'm the craniofacial orthodontist for the Duke Craniofacial team.
When a baby's born with a cleft, it can involve a couple of different structures. It can involve the lip, it can involve the gum line, and it can go all the way back into the palate. And the most common type of a cleft is one that goes all the way through the lip and the gum and the palate, and that's a complete cleft, and that's half of all the kids that we see. A lot of times people talk about the severity of a cleft, and they talk about the width or the distance between the two sides of the cleft, because what the cleft does is it actually, it creates a separation between two sides of the face. If the two sides stay connected, if there's tissue that goes across, then that's called an incomplete. They would say less severe because it doesn't look as wide. The closer the two sides of the face are together to one another, then the easier it is to repair it. Historically, there have been methods to kind of bring these two sides of the cleft together, and they worked to a certain degree. But we're going to hear about a technique that is, in the current time, the standard of care now, called nasoalveolar molding.
So nasoalveolar molding is a pre-surgical orthopedic technique for children that are born with a cleft lip and palate. It was originally developed at NYU by my mentor, Dr. Barry Grayson, in the early 90s.
One of the things that this nasoalveolar molding does that none of these other techniques could do was make adjustments in the nose. So the nose is probably the most important structure in defining the quality of a result later on. What nasoalveolar molding does is that it actually starts to form and mold and shape the nose in ways that the surgeon can't necessarily do himself or herself. We get a lot of families now who've had a diagnosis made by ultrasound. They'll get their information a little more slowly in a controlled way so that they're not getting overwhelmed with so much right away. But typically, like in that type of consult, Dr. Santiago and I will meet with them together. First thing that they should know is that there's nothing that they did to cause this. We call it multifactorial, which is a way of saying that we're not totally sure exactly why they occur. There are a lot of things that probably can influence a cleft, but it's not something that they did. So I think that particularly moms can feel a lot of guilt, feel as though they might have done something, eaten something, which is just not the case.
So we found out about Anna's cleft lip and potentially cleft palate at the time when I was 18 weeks pregnant. She spent a couple weeks in the NICU initially, so we actually got the NAM later than the typical time frame. So I believe she got it about 5 weeks old, around October of 2015, and she had it until January of 2016, and then she had her first lip repair surgery in the beginning of January of 2016.
So Austin was born with a unilateral complete cleft lip and palate, which involved his lip, his gums, his hard and his soft palate. We used the NAM for about 15 weeks, at which point we just had our first surgery with Dr. Marcus, which repaired his lip, connected his gums, and his nose.
He was a surprise cleft baby. We did not know that he had a cleft until he was born. When they lay your baby on your chest and you're like, oh, you had no idea, no clue that it was coming. It's a big shock. It is.
I think everybody wants their perfect baby. When you see your kid and you see that he's going to immediately have to overcome this obstacle, it's hard on you. In that regard, you're kind of holding your breath until you can get the surgery done.
There's a lot of work involved, and so it is a little bit labor intensive for the families to do this. And the question comes up about, why should we put all of this effort into it? The best opportunity to do the repair is at that first operation. And so you need to have things set up as perfectly as you can to a point where it's no longer severe.
My first question about the NAM was, how does it work? And after asking the question and then also seeing the treatment, how I picture it is the NAM, it does two things. It molds the baby's gums and nose and lips, but also uses the fast growth of an infant to its advantage. The device itself isn't moving all of the tissues. He's growing into what the NAM is doing.
The nasoalveolar molding technique is actually pretty simple. It's a non-invasive appliance, We just take an impression that takes about 2 or 3 minutes with the surgeon, and we create a little plate. It's like a retainer. So every week, the patients will come to the clinic, and I do just a little modification to that plate. And then at home, with the help of some facial tapes, the mom or dad, they will adjust the appliance and then produce that little force that will just get those segments together. So every week, they produce 2 or 3 millimeters of reduction on that cleft gap for us.
My big concern was, are we going to get enough value out of it for the trouble that we're going to put into it? During that time period, it was tough. It's hard to make your baby cry, you know?
This is not bothering them. This is just something new, and they hate anything new. You want to see? Just relax.
So we were like, oh, this is really easy, doing just fine, you know, the first couple of weeks when it was just the portion in the mouth. And then when they added the nose stent, that's when it got really rough. And I remember thinking, oh goodness, how many more weeks of this? Looking back, you know, I kind of laugh about it because at the time I just felt like I was doing this horrible thing, but really it's just because that's not what she wanted to be doing at that point in time.
The appliance doesn't hurt. The babies don't speak, so they cry. When you're not activating the appliance or when you're not messing with them, they don't cry at all.
She was trying to, I think, breathe through her nose, and it made a funny sound, and so I just kept thinking, but she can't breathe. And she's very dramatic. Dr. Santiago told us from the get-go. She would scream at all of her NAM appointments, and none of the other babies really did that, so I always just thought, well, she's just in pain. These other babies aren't. And he assured me she's not in pain, she's just dramatic. And I thought, well, how does he already know this? She's, 5 weeks old. Now getting to know her personality, she's dramatic. He was right.
It usually takes about 10 to 12 weeks for the unilaterals and about 20 weeks for the bilaterals. So 3 months for the unilaterals, about 5 months for the bilaterals to get the results we want before the surgery.
It's very scary. I, as a mom, showed up and I was probably on the verge of tears 3 times during the appointment because you're scared that it's going to be painful to them or they're not going to eat afterwards or that it's just going to be uncomfortable in some way. But when you're there in the clinic, Dr. Santiago has created an environment that's very supportive. It's not painful. And it is a good thing, and there are other moms to talk to, and there are other babies to see in various stages of the NAM treatment, that when you get there, all of those fears and the worries don't go away entirely, but they're reassured in that he's going to be okay.
5 years ago, one day in our clinic, we were very busy, and I used to see the patients one at a time. And I didn't have a lot of time that day to see about 8 patients that we had to see, so I told my staff to bring all the patients to the clinic. And then something magical happened, and it was just by serendipity. All parents started talking to each other, and then I realized that that's the way I had to treat them. The NAM device has been developed through the years and has improved based on parental feedback. So I listened to them, and then we make changes to that appliance.
Once you're in it for a long time, their cheeks start getting a little bit irritated from the tape and the continuous wearing, and so he would scratch at it and want to pull it off. So by the end, we just really had to be cognizant. But it really wasn't difficult. It's really just a lot of effort.
As we were going through treatment, we began to see the results of the NAM and the progression that it was taking and making and how it was preparing him for surgery. So it was a little bit more foolproof of a plan and reassure us that while it's a little bit of a rough patch, we knew it was going to be worth it when we were ready to hit the operating table.
The big value piece for the NAM is you're essentially molding his nose so that you'll get a more, symmetrical product after the surgery.
It was one of those counting down the weeks, just getting through it. But I would do it 1,000 times over.
So if we have a prenatal diagnosis and the parents come to our clinic, they gather with the other families, they know exactly what NAM is going to do for them. We show them pre and post photos of cases similar to theirs, and then they're ready. They're ready to start, and really, really lowers the stress level.
All right, this is Austin Reedy. His birthday is 10.
When it comes time for the actual surgery, I'll have a conversation with the family about how to prepare. I think one of the things I've learned over the years is just that most families, if they just know what to expect, even if it's something that may be scary to them, like swelling or any type of bruising, but if they know what to expect, then there's not so much anxiety about it when they actually do see it. And so we go through that, and we talk a little bit about the surgery and the risks. Of course, cleft lip repair, among types of surgeries that you do, they're done all over the world in a whole variety of different kinds of conditions. And so from a safety point of view, it's a very, very safe operation. The risks are very, very few. I'd say bleeding or infection are extremely rare. And the thing that's probably most realistic, which to me is really important, is just the risk of it not being perfect. And there are always some imperfections, and we cannot make it perfectly symmetric. But we want to get, our goal is we want to get it as close as anyone possibly could.
As a craniofacial orthodontist, my role is actually to reduce the number of surgeries that these kids will have. But it's funny to say that I work in a plastic surgery department, right? So I'm not putting surgeons out of business. It's just that our goal, and we're very proud to say when we go to meetings, that we are one of the centers with the fewest amount of surgeries to solve the problem. So the beauty of doing pre-surgical orthopedics and surgery is that you can reduce the amount of revisions or even surgeries that these kids will have in the future.
Cool.
Yeah. Do y'all have a bottle, a special bottle for him? Yes. So we'll start with some glucose water and then breast milk.
We have to go get milk.
Which side? This is the fentanyl for him. They gave him Tylenol, but that's good. How's he doing?
He's doing so good.
Oh,
He's a fighter.
The moment we saw him after surgery was very emotional. There's not a lot of words to describe it, but you see a new kid and a new face, but the face that's so familiar to you at the same time, and it's just really amazing.
Yeah, I know it sounds weird to say, but I didn't even recognize him at first. It just seemed like a brand new son. It just seemed like a brand new face. And it did take a bit of getting used to. And not that I miss the old face, but having seen him in his new face, it was quite a relief.
okay, perfect, yeah. Was that in the floor order? Okay, I forgot to look there.
I would say don't be hesitant to go through the process of the NAM. Yes, it's tough. Yes, it's difficult. Yes, it's a daily commitment to your child. But in the end, it's absolutely worth it. Now that we're through the treatment, it seems like a far distant second inconvenience to our daily lives when we were going through it at the time. But if we could go back and do it all over again, we would.
The pleasure that you get from doing it, is probably the most important thing. So, on the one hand, you could say, well, I'm not saving lives every day, but, I'm doing some things that are changing people's lives for their entire, growing up. I mean, from the time that they're born, what we're doing is a lifetime. It can last a whole lifetime. So we had our clinic today, and, one of my little patients who I met when she was a newborn brought her school picture in, and she made me a little picture, and it says, "Thank you, Dr. Marcus, for everything you've done for me," and it's a little picture of her and me. So, it's like the MasterCard commercial. That's priceless.
It's just amazing just to see them grow, to see them change. I do not have one parent that has gone through treatment that says that they will not do it again.
We are blessed to be able to be given the opportunity to do this. It's a privilege to be able to do what we do. And the cost of having that privilege is the pressure of having to do it better than everybody else.